tonight, we will present evidence that has been used by government bodies to make the decision about whether or not to cover breast cancer screening in women ages 40 to 49. Jeff Tice is a UCSF professor, and he will be playing the role of the plaintiff's attorney. He will be arguing to support coverage for mammography beginning at 50 rather than 40. Rita Framanis, also a UCSF professor, will be playing the role of a defense attorney, and she will be supporting coverage beginning at 40.
All right. Good evening. Thank you for attending tonight's trial. Let me give you an overview of the process. First, there are going to be the opening statements of the attorneys, Dr. Tice and Dr. Framanis. After that, there will be 1 hour of testimony from the expert witnesses, followed by the closing statements by the attorneys. Then you will convene in juries of 8 to deliberate for 20 minutes. You will need to reach, in order to reach your verdict, you will need to have 6 of 8 votes. You will not need to have a unanimous vote. Okay. Ballots will be provided. Copies of slides will be available. And the question you have seen: for average risk women, should mammography begin at age 40 as opposed to beginning at age 50? Be covered by publicly funded programs? Yes or no?
These 2 studies contributed more data to this analysis, and this effect on mortality has been blunted by adding more data to this. So this was a surprise to some folks when this came out, but the bottom line here was current evidence shows a 12% reduction in breast cancer deaths with screening women aged 40 to 49 that is not statistically significant. I want to show you another a way of looking at the data, similar data, in some ways the same data, but looking at this in a different way. What does it mean to have a 12% decreased risk of death? Well, 12% of what? We have to know something about the absolute risk. That's why another way to think about this is thinking about if you were to screen women of these certain age bands, what could you imagine in terms of how many deaths are averted with screening 1,000 women over a 10-year period of time? So this puts it in more of an absolute risk rather than a relative risk kind of a metric. I want to skip down to here to show you that in this analysis, and this is using the same data that I just showed you, but it's in a different metric, women 50 to 69, in that age group, you would have to screen, if you screened 1,000 women over 10 years, you would save about 1 life in terms of decreasing breast cancer. So you would save 1 life after screening 1,000 women over 10 years. Skipping up to 60 to 69, you see this is really where mammography seems to work the best. After screening 1,000 women over 10 years, you would save 2 lives. I want to show you what this means. This tells us about the precision of that estimate. So for women in their 60s, you may, over a 10-year period of time of screening 1,000 women, save 2 lives, but it could be as few as only 1 life, and it could be as many as 3 lives saved. That tells us about the precision of the evidence we have. Now, focusing again on this 40 to 49 group, we see that if you put it in this metric, that it's about 0.3 women's lives saved per 1,000 screened over 10 years. If a 0.3 woman makes you nervous to try to think about, the bottom line here is the observational studies show a greater reduction in breast cancer deaths with screening than the randomized trials show, but these seem to be a bit more similar in their reduction.
Okay, thank you. Let's go back to something you said. You mentioned that the experiments or the randomized control trials are the best evidence that we have. But these trials have some major problems, don't they? For example, many of them were done very long ago, and technology, such as mammography technology, has greatly improved over time, right?
That's right. So I want to show you some of the strengths and limitations of these experiments that we've been putting a lot of emphasis on. The strengths of these studies is that they've enrolled a lot of women. Over 500,000 women have been enrolled in these trials over the years. The follow-up has been really quite long-term, as short as 11 years, but as much as 21 years in that one Canadian trial I showed.
You highlight that many of these trials are old. You also highlighted one of the trials, the age trial, specifically looked at women in this age group. Was that one of the older trials or one of the more recent trials?
That's one of the more recent trials. As a matter of fact, it's a trial that, as I mentioned, is still contributing evidence and outcomes that did have an effect on this summary estimate of effect in this women 40 to 49.
Great, thank you. And I just wanted to clarify one thing. You said there was, in some of the trials, mortality reduction, but you don't really mean that, right? You really mean a decrease in death from breast cancer, not all deaths.
That's correct. So when I say decrease in mortality, it's breast cancer specific mortality.
Great. Dr. Kurlikowski, would you describe the harms that a woman might expect from screening mammography?
Most common harm that a woman could experience with mammography are false positive results. So how might a woman experience a false positive mammogram? When women undergo screening mammography, the radiologist is looking for lesions that might be cancer. But from a screening mammogram, you can't definitively know whether someone has cancer or not. So if they find a lesion that they think might be cancer, they call that mammogram positive. But you need to do further workup, as mentioned in the opening statement. Sometimes you need to do additional imaging with diagnostic mammography and or ultrasound, and sometimes women get both tests. And by magnifying the lesion, you get a better sense, is this lesion cancer or is not cancer? If it's determined that it's not cancer and no further workup is needed, then that woman experienced a false positive or a false alarm, where she was concerned for a couple days and maybe anxious because she didn't know if she had cancer or not until she had the additional imaging. Sometimes women have to take off work, and sometimes the anxiety can last up to 3 and even 6 months later. So that's the most common. Second to that is a false positive biopsy. So after the additional imaging, if the radiologist determines that they're still suspicious that it might be cancer, the woman goes on to have a biopsy. And those biopsies are usually what they call core biopsies. And the needle is quite a bit bigger than when you get your blood drawn, let me just say. You have the core biopsy, and then they tell you whether you have cancer or not. If you don't have cancer and your lesion is benign, that then is what is called a false alarm or false positive biopsy, because you underwent a procedure and were told you didn't have cancer.
Dr. Kurlikowski, you have been describing these outcomes in terms of per 1,000 women, right? Saving roughly 1 death per 1,000 women. That may not sound like a lot of lives saved to these people, and you just told us there are 22 million women in their 40s in the US. So couldn't that represent a lot of incidences of breast cancer deaths averted if we screened women in their 40s, those 22 million women?
It could, if you believe that mammography is efficacious, but it also means millions of additional tests and biopsies in healthy women who have, otherwise, no health problems. So it's actually the millions showing like how many false positives and false positive biopsies occur in these women.
Yes, it's a big effort, I agree. Also, because we've already discussed the limitations of the older trials, the randomized clinical trials, and we talked about the fact that the newer observational studies show a greater benefit, even with all their flaws, isn't it possible that the benefit of that the magnitude of the benefits we've talked about could be even greater than demonstrated?
I guess it's possible, but I'm doubtful, because I think the incidence of disease is low in women 40 to 49. We're not really going to change that. And we evaluated with the modeling studies the newest technology. And I forgot to mention, those are optimal numbers. Those modeling studies assume 100% of women get screening, so they completely comply. In the age trial, which did not show a benefit, in that trial, 60 to 80% of women underwent mammography, and that's about what it is in the United States as far as compliance. If you ask someone if they had a mammogram in the last 2 years, depending on the age group, it's usually about 60 to 80%. And in that particular age trial, only 0.5 deaths per 1,000 were noted, not even the one where we had 100% compliance with utilization. So I'm actually think the 1 per 1,000 is optimal, and I think it might actually even be less than that.
Thank you. I have no further questions, Your Honor.
Dr. Kurlikowski, you may leave the stand.
Everyone agrees the highest quality evidence, the randomized trials, demonstrate a much larger benefit for women 50 years and older than for women 40 to 49. In fact, the benefits for women in their 40s do not reach the standard for proven beyond a reasonable doubt that is used in medicine. That is less than a 5% chance of making an error. In other words, the best evidence from the randomized trials suggests that there may be no benefits at all to screening women in between the ages of 40 to 49 with mammography. The observational evidence suggests benefit, but observational evidence about healthcare behaviors has been shown over and over again to be subject to biases that cannot be overcome through clever study design or statistical manipulation. For instance, observational studies consistently found a decrease in heart attacks for women taking hormone therapy, but the randomized trials consistently found an increase in heart attacks. Furthermore, over a lifetime, the harms of screening are cumulative. So beginning screening at age 40 maximizes those harms. The harms are unequivocally proven, as you've heard today. False positive biopsies, false positive findings resulting in extra testing, anxiety, and unnecessary breast biopsies. And most important, overdiagnosis, which leads to overtreatment. That is surgery, radiation, and sometimes chemotherapy for tumors that were never going to impact a woman's health. Smart, informed, reasonable people have come to different judgments about whether to recommend screening for the average woman beginning at age 40. Neither the American Cancer Society nor the U.S. Preventive Services Task Force recommend screening for the average woman. And that's what we're talking about today, average women, not high-risk women. For high-risk women, screening is recommended. So we're not writing a clinical guideline today. We are judging whether screening mammography beginning at age 40 compared to age 50 represents a good value for that $1.3 billion investment every year. It's difficult to put a monetary value on health outcomes, but we have a moral obligation to prioritize high-value care. And it is clear that screening mammography between the ages of 40 and 49 has significantly fewer benefits, possibly none, and significantly more harms than waiting until age 50 to begin screening for the average risk woman. Healthcare costs have risen to unsustainable levels, leading to higher insurance premiums for consumers and higher taxes for all of us. We have to target areas where the costs are high and the benefits are small so that we can pay for new high-value care, such as personalized therapies that cure cancer or prevent disease. Given the evidence presented, I think you will all agree that covering mammography for women in their 40s represents a low-value option and should not be covered. Thank you for your attention.
You've just heard about the large cost of screening. Yes, the cost is significant, but the benefits, while smaller in this age group compared with older women, still outweigh the harms and can justify this cost. How great is that benefit after all we've heard today? You've heard that screening women starting at 40 is estimated to prevent about 1 death per every 1,000 of women over screening of a lifetime. And since there are those 22 million women that age in the US, a total potentially of 22,000 lives could be saved in that group. That is a lot of lives. I'll help you also now better understand what we mean by harms, and that most women tolerate those harms or false positives very well. Women in their 40s do get recalled for additional imaging, a little bit more than older women, but the vast majority of these additional studies turn out to be normal and just fine. And whatever anxiety is incurred during that period, it's much better than the difficulty of having a cancer diagnosed later and undergoing treatment, and that takes a lot of time off from work. So as to the related harm of a benign biopsy, the biopsy rate is no higher in this age group compared to older women. And most of the biopsies are done with a needle, smaller than a venipuncture needle, bigger, but not much. And it seems that most women who have a benign biopsy seem very happy, as I said earlier, to find out that they do not have cancer. The other potential harm that we talked a lot about, the overdiagnosis, I don't think should be a major factor in our decision, because we really don't know how often it occurs. And maybe instead, we need to focus more on figuring out whether to treat or how to treat those lesions that we find, instead of choosing not to even look for them. The problem is not that we're diagnosing something that's not there. The problem is that we are seeing something and then we're treating it. So we need to figure out how to deal with them. And for those women whose biopsy shows a non-invasive cancer, they can discuss with their oncologist how to best manage that. Or if a biopsy shows a precancer, a high-risk pathology, they can talk to their doctor about risk reduction therapy. And now for those women for whom the potential for false positives causes undue distress, they really can't take the anxiety, they may choose to delay screening until their risk rises even further as they get older. But the woman who desires to do everything she can do to allow earlier detection of a potentially lethal cancer that may be growing in her breast, she should have the opportunity to be screened. Finally, any decision that you make here today will have some uncertainty. We're not going to solve today what countless scientists have not been able to agree on for decades. But we place value on principles that we hold dear, such as saving lives, and we accept the reasonable compromises and costs that make it possible to save the lives of these women. Thank you.
Those Viagra pills, I mean, they don't make any sense.
So
People got two philosophies. So I'm really suspicious about if you were
we'll read them. So that's
It's
the
good to
next
focus on the
the
issue
judge will
of
read them.
studying breast cancer.
And then when we're done, and then we do interviews with some of the jurors and then set them. That's happening. I think they're going to want
way that would help me to get my head around it is to say if you have $5 billion that you want to invest in women's health, so it's all women's health, it's not going to go spent on Viagra. Then within that $5 billion, do we want to invest $1.6 billion on this versus providing non-patient care or other that's maybe helps kind of bring our question.
No, I'm not.
I think after all those biopsies that I don't have what I thought. I had an experience where I
But it's worth discussing. Yeah, exactly.
guess in 10 to 20 years from something that's widely used in the long.
We will be reading the verdicts now.
Go ahead.
Good. The ballot for jury 1. What's the color? They're all
It's 1, 2, 3.
1, 2, 3 going down like this. I didn't know that. Ballot for jury 1 is yes. The ballot for jury 2 is no. And the ballot for jury 3, the tiebreaker, no.
So let's talk about this a little bit now. First of all, it's hard, right? And that's what we're trying. The goal of this and all of healthy discourse is to bring out the stuff that's hard but important. It's super important, and yet it's hard. Just to frame it, even if you take the optimal model, assuming optimal implementation, one life saved, but 2 women get full breast cancer treatment who would never benefit. So get surgery and radiation, and it doesn't benefit them for every 1 life saved. Now that's just really hard. Would you want that? Even as an individual, would you want that? And then as a society, do we want that, and do we want to pay for that? It's just hard.
I just think that there's a difference between a population, there's statistics on the population, and then the individual sitting in front of you. And often those statistics, depending on how they're put together, don't strictly apply even to that individual. So I think I had questions as the evidence was being presented about its particular angle.
Well, thinking back when I was in my 40s, it was good that I had it because there was a lump, and fortunately, even though I did have it out, it was negative. The radiation, I do question how much exposure to it. Yes. And then there's CAT scans. How much exposure, to radiation is there with that as opposed to X-rays or mammogram?
I carry the BRCA1 gene, and I did in fact at one point have a breast surgeon tell me that my risk for breast cancer was rising exponentially and that I should have a double mastectomy immediately. And I went away and remembered something a genetic counselor had told me about retiring, having lifetime risk and retiring portions of this risk over time. And those two didn't add up. So I'm the kind of person who went and actually did a lot of reading, a lot of research, and ultimately opted for very close surveillance. I have a mammogram I've had mammograms every single year since I was 35 years old. And I now have an MRI every year as well as I get older, because that increase, that risk is there. I also had my ovaries removed, which actually significantly decreased some of my risk. So it's a complex picture.